about what you already know, but what are the practical challenges which comes to make a clinical diagnosis? When it comes to the interpretation of investigation, how do we interpret as a clinician? What are the factors we need to look into the things? And what are the challenges we face when you're managing the cases? This is a 10-year-old child. Straight away we'll go to the case. 10-year-old child came with an history of an high-grade fever associated with a rash and pain abdomen for 1 day and cough for 1 day, 1 episode of a vomiting, and the last 12 hours the baby is not passed in a urine, no history of any chorus or breathing difficulty, no history of any travel in the things. When we examined this child in an emergency department, the temperature was 101 with a blood pressure of 94/76, saturation is well maintained with a respiratory rate of 20, with lethargic and maculopapular rashes over the trunk, and the cold peripheries, the volume of the pulse was low, abdomen was tender in the right hypochondriac region, chest was clear, and rest of the examination except rashes and blanching palms and the soles over that. So rest of the things were quite normal. So the moment we think about these things as a clinician, which comes in the clinical practice is what are the differential diagnoses we think. Of course, there will not be any challenges in thinking about what will be the line of investigation. So initially we thought it is a dengue with a warning sign because the child had a fever, abdominal pain, tenderness, everything was there. And leptospira was the other thing, enteric toxemia and rickettsial fever, abdominal sepsis, multisystem inflammatory syndrome. These are the things which comes in the mind the moment we think about these things. So with that, this child has been investigated. Look at the hematocrit, HV is 13.8, hematocrit is 44, leukopenia. So with the lymphocytes of 40% and CRP was normal, mild elevation of SGOT, SGPT, dengue NS1 antigen was done, which is positive. And INR is 1.3 and type E dot test is also positive. Since it is in a pandemic of a COVID-19, we sent in a COVID for RT-PCR, we have sent an RT-PCR. The thing here is what the challenges when you look at these investigations. One is NS1 antigen is positive, IgM, IgG for dengue is negative, and type E dot test is positive. So how do we interpret these things? These are the common challenges we all face it in day-to-day practice. So looking at an NS1 antigen, looking at the clinical picture, that's really fitting into the case of a dengue. That's clinically it fits into the dengue. But enteric toxemia is one of the clinical condition as a practitioner, we need to keep it in mind where type E dot test is positive, but type E dot test is not a reliable thing. But what we need to be looked in this type of a thing is we need to depend more on the clinical condition rather than the investigation. So we thought it is a most probably we are dealing with a dengue as a thing. So that was the challenges what we have faced. So the most important thing is once you make a clinical diagnosis, interpretation of investigation needs to be looked always with the background of a clinical knowledge. Otherwise, so you will end up with a multiple treatment. That's why we need to look at that. We did not think about enteric fever here. We thought in terms of anything as a thing. So the next priority which comes is in a management. That means once you make a diagnosis of a dengue, so your things needs to be looked into that. Already Professor Tangavelu sir is already discussed about dengue in the morning. I'll not explain. What is most important when you're managing a dengue is we need to give in a crystallite that is normal saline and ringer lactate, whereas a dextrose containing fluid needs to be avoided when we are dealing with a patient with a dengue with a shock. During the maintenance, our answer is yes. During the maintenance, you can consider a DNS, but in the early stage, it is a crystallite that is normal saline or a ringer lactate. And we need to restore the organ functions. That's the most important. Capillary leak is likely to cause a multi-organ dysfunction. Strict monitoring is the thing, supportive care, and we need to look at a platelet count and hematocrit. This child, in spite of starting in a crystallites with almost 30 ml per 4 ml per kg, still the child is having a tachycardia, saturation is maintained, look at the blood pressure, and the volume of the pulse is still low. Urine output is not really made an improvement, it is 0.5 ml. The meanwhile, we had another challenge. Now the COVID RT-PCR is positive. Initially, it was a dengue NS1 positive and typhoid RT positive. So looking at the clinical condition, we thought it is in a dengue. So we were treating. Meanwhile, your COVID RT-PCR has become positive. What will be your thoughts at this stage? Should we treat like a COVID, like a multi-system inflammatory syndrome, or should we treat like in a dengue? That's what, as a clinician, we'll face in a lot of challenges in the clinical practice. So when we look into these things, since it was fitting into the dengue, it is not like in a multi-system inflammatory syndrome. So we went ahead with the things. But remember one thing, in a patient, when you're dealing with this type of a thing, false positivity of a dengue is a known thing, especially IgM, IgG, which is known thing. But sometimes it could be a true dengue with a COVID, needs to find the severity of each other. We need to look at that. If it could be in both dengue as well as a COVID, co-infection is quite possible. So what we need to look at that when you're treating the things, we need to look at the clinically what it is fitting into. We need to treat that as a priority basis. So where dengue can also be present within the moment we say respiratory complaints is there, it is not a dengue. That statement is holds good in older children and adults. But in younger children, dengue can also be present within a respiratory manifestation. So need not to be, that's why we need to keep that into the mind. Many of the COVID can present without respiratory symptoms. That also we need to keep it in mind. Clinical picture will be in a challenging situation when you're interpreting the investigation. So unpredictable course and difference between the infection and seropositivity, we need to look. These are some of the real challenges as a clinician. We all face it in day-to-day practice. So when you look at these clinical symptoms, is there any difference between the COVID-19 and dengue? So fever can be there in both the condition, but headache is a more common retroorbital headache in the older children, which is much more common in a dengue. And purpura, which is more common in a dengue, it is not in a common manifestation of COVID. These are the things we need to be remembered on that. And persistent vomiting, abdominal pain, especially during the critical phase. In the febrile phase, pain abdomen is not a clinical manifestation. Between 4 to 6 days, that's the time, where 3 to 6 days, that's the time. The moment the child fever disappears, abdominal pain appears, and persistent vomiting, that is the stage where the child, which is moved from the febrile phase into the critical phase, that's a more common in the dengue as compared to the COVID-19. So meanwhile, chest X-ray, which was a normal, and ultrasound was done. So we need to look at the cardiac contractility, fluids in the lung, and fluid status, especially look at the IVC. That will be very, very useful. Since we are thinking about multi-system inflammatory syndrome is also one of the things, we looked into the acute phase reactant, where acute phase reactant is mild elevation. Acute phase reactant can be elevated in both in dengue as well as multi-system inflammatory syndrome. But the one thing you should remember, it will be in thousands in a case of multi-system inflammatory syndrome compared to that of dengue. But so it is not going to differentiate between the MIS-C and dengue. Only the clinical picture and other things we need to be looked in. And SGOT, HGPT, which was elevated in the beginning also, and it was maintained. Another thing, as a clinician, since the child has a COVID RT-PCR positive, should we start with any antiviral drug? Answer is Indian Academy of Pediatrics, WHO clearly says there is no role for your hydrochloroquine, azithromycin, or favipiravir, or remdesivir. On case-to-case basis, you can consider remdesivir. Otherwise, there is no role for an remdesivir, even if it is a COVID RT-PCR positive. This patient, COVID RT-PCR is coincidentally is positive. So we need to treat dengue as a major thing in this. So child was required escalation of a fluid. Initially, it was in a 4 ml per kg of a fluid was given. Then later we have increased, but child did not make an improvement in spite of increasing the fluid. So colloid is one of the thing. Albumin is the one thing we all use it in the practice. So in our ICU, so this child was started with an albumin. So subsequently, the child within a low dose of an epinephrine, child has made a quick improvement in the next 4 to 6 hours. Urine output, which was initially 0.5 ml, which is increased to the 1.5 ml. Sensorium is normal, and hematocrit has decreased, and platelet count is also improved. So fluid is the one thing we have continued it later. So this is a challenging situation. So initially typhoid was positive, COVID was positive, dengue was positive, but clinically it was the physiology was more severe with that of a dengue. We managed like a dengue, and what COVID was required, just isolation. That's what we done for the next 10 days. What did we learn out of this case? What are the challenges and what did we learn out of this case is, whenever there is an epidemic or endemic of a dengue, so and pandemic of a COVID, co-infection is known thing, and false positivity is also possible, especially IgM, IgG for dengue. We need to be careful about the clinical condition. You need to treat the clinical condition. And if the COVID RT-PCR positive, we need to isolate these children. And once again, in a COVID ICU, managing a dengue and COVID is a real challenge because people will not be moving that much. Those are the things. And we need to keep a track on acute phase reactant like your CRP, ferritin, and coagulation profile, monitor the trend, be vigilant with the symptoms and signs of respiratory signs and unexplained things. If anything which is arises, we need to that. And COVID, we don't require any specific management. Dengue, it all requires your organ perfusion. That's the case number 1. Let's move to the another case. It's a 2-year-old female child brought with a history of a fever for 10 days. And child had a rashes and maculopapular, which is on 4th day of a thing, and swelling in the lower as well as upper limb, and altered sensorium on day 9, and convulsion just few hours before the admission to our ICU. So generally what the message is, in a case of a pyogenic meningitis and viral encephalitis, generally there will be a prodrome in a viral encephalitis followed by convulsion in the usually 3rd and 4th day. That's the clinical manifestation in a viral encephalitis. Whereas in a pyogenic meningitis, unless it is a partially treated, usually convulsion, these things will be in the beginning of 4 to 5 days only. But this patient had a convulsion on the 9th day along with the rashes. So if patient is coming from an endemic area, just you can see there is a child with a bilateral pupils auricle, no icterus, and the maculopapular rashes, which is there all over the body, and purpuric lesion, erythematous flakes, and involving the upper limb, lower limb, dusky and purpuric lesions, and dry gangrene was there. You can see these things, gangrenous things, and fetal edema, and reticular papular rash, which is erythematous flakes. So diagnosis is not a difficult thing. When you look at these things, you can see this is an Yeshkar. So your diagnosis is certain. It is a rickettsial fever. Previously, we used to think about meningococcemia is also a differential diagnosis. So last 1.5 decade, where a lot of cases of rickettsia we have come across. So diagnosis was not a major issue here. This child we diagnosed as a rickettsial fever, and investigation also anemia, leukocytosis, platelet count of 1.2, wheel pelix was OXK, that is Krupp typus of 1:320. Even though we have a lot of pitfalls in interpretation of a wheel pelix, but still it is a very easily available test everywhere. So we diagnosed as a rickettsial fever. And since the child was in an altered sensorium with increased ICP, all supportive measures including mechanical ventilation and fluid is titrated depending upon that, and anticonvulsants was given, and antipyretic, and child was started with a doxycycline in the dose of 3 to 6 milligram per kg. What the challenging thing here is, child sensorium is improved within 24 hours, no convulsion after loading with a phosphorentyne, vitals were stable within 2 days. Child was developed in another issue here is high-grade fever after 6 days of doxycycline. This is where, as a clinician, we will face a challenge in the clinical practice. So, diagnosis, there was not much challenge. It is a rickettsial fever. Investigation was supportive. Treatment was, we know that it is a doxycycline. Child has made an improvement. What this thing is, developing a fever on 6th day, the first thing which comes to the mind, are we dealing with any co-infection in the present era of any things like a COVID or a malaria and other things we need to be looked in. Apart from that, this child was there with us for more than 6 days. Another thing we need to keep it in mind, of course, nosocomial infection needs to be looked in. Drug fever is another thing we need to be, and rickettsial fever, which is resistant to doxycycline, it is not a common phenomena because of vasculitis and all. We need to keep that in also in the mind. But apart from that, what is other important is a sepsis mimics like your HLH, all those things we need to be kept. This child, we thought about, since it is developed as splenomegaly, and leukopenia, thrombocytopenia, ferritin level was high. So HLH was thought, we diagnosed as an HLH, and we treated with like an HLH with an with an dexamethasone and etoposide. Child was made an improvement. The message here is, just you don't think about infection in this type of a cases, you think behind infection also. So nosocomial infection like sepsis mimic, like HLH is one of the things. Last case, just I'll finish it in 5 minutes. This is a 3.5-year-old male child presented with a fever for 15 days. Fever was insidious in onset, gradually progressive, not associated with chills and dry. Child was not active in between the fever, no other complaints, and there was an hepatomegaly, which is non-tender. So these are the investigation. There is an leukocytosis with neutrophilic things with the platelets of 2.5 lakh. Vidal test was positive. So initially we thought about enteric fever as a possible thing. Apart from that, we thought about rickettsia, malaria, UTI, because this is an FEUO. We thought about brucella also, one of the things. This child, when we investigated, look at that. So leukocytosis was there. So, and apart from that, SGOT, SGPT was a mild elevation. And CRP is not that much elevated. And Vidal repeat was positive once again. And child was started with thinking about enteric fever as a thing, started with ceftriaxone, blood culture sensitive was awaited. So we started with ceftriaxone thing. Since the child did not make an improvement, we started with azithromycin. So subsequently, we had a blood culture which was resistant to the ceftriaxone. That was the reason why this child was not responding, and it was sensitive to the meropenem. Since we started with an azithromycin, so we just continued with that. What the message we wanted to convey out of this case, enteric fever resistance is an emerging clinical problem in your office practice. We need to be more aware, even though the cases has been reported in the Pakistan and all, but we need to be in our own center. We had 4 cases of enteric fever, which is resistant to ceftriaxone. So, and ciprofloxacin and quinolone group of a drug resistance, which is already known. So extensive drug resistance to the typhoid is an emerging problem. As a clinician, we need to anticipate these things, and we need to be aware about these things. So thank you once again for giving me an opportunity to talk this thing. Thank you.
Thank you, sir, for your excellent presentation on unusual challenges that the practicing pediatrician needs to pick up when especially during this pandemic, we are fighting with COVID. So,
thank you, sirs. If we do not have any questions from the floor, may I now request the chairperson, Dr. Jalil Ahmed, to hand over the memento to the speakers. Dr. Prasad Mani. I request the chairperson to hand over the memento to Dr. Basavaraja.